risk stratification tools are really crucial in the management of patients on surveillance. The first point, I think, is that using standard clinical parameters, age, race, PSA density, extent of disease on cores, number of cores involved, you can have a very good predictor for the likelihood of the patient harboring higher grade cancer. My group at Sunnybrook has developed one of these, so have others. So there are in existence very useful risk predictors to try and identify the patients who are at higher risk. The second thing, of course, is MRI. Now, the MRI story is evolving extremely rapidly. So there is new data almost every month on the performance of MRI in men either undiagnosed or with low-risk prostate cancer that's relevant to the question of how accurate and how well MRI performs. The data at the moment, in my opinion, is somewhat contradictory. There are some extremely positive MRI papers. The one that comes to mind is by Panabianco, another one by Siddiqui. Both of these report negative predictive values for clinically significant cancers. It's 100% in the case of the Bianco paper. It's about 95% for the Siddiqui paper. But there's other studies that show actually it doesn't perform as well. And this probably reflects the patient population, maybe the equipment, the expertise of the people reading it. The targeted biopsy also involves a skill set that may vary between centers. So MRI clearly has a role. Whether it's going to allow us to replace the biopsy entirely, I think, is not clear. There's clearly a percentage of patients who have clinically significant cancer that don't show up on MRI. So the way I see this unrolling is we're going to have risk nomograms like we do now, for example, for who should have a biopsy based on PSA and other risk factors, for the active surveillance like the one I mentioned, and I foresee within the next couple of years, because a number of groups are working on this, we will have a risk nomogram that incorporates the PIRAD score from the MRI, along with all the other clinical parameters like extent of disease, number of cores positive, etc. And that will be a much more accurate nomogram than we've had in the past. It's not a black and white situation. So if the guy, for example, has a negative MRI, but multiple other positive risk factors, he should probably still have a biopsy. Similarly, there may be patients with a positive MRI that's Gleason 6 on biopsy that, that doesn't need to be treated. So we are clearly in the risk nomogram era, and I think they will have an increasing role as we incorporate these new diagnostic tests.